Good evening, everyone. My name is Elias Lima. I'm a medical oncologist. On behalf of our uro-oncology team of OncoMed Group, I would like to thank you all the audience for participating in this web meeting, and also the Pfizer staff for their kindly support. We have a special guest this evening, Dr. Thomas Pauls. He's director of Bart's Cancer Center in London, UK. Dr. Pauls has a vast experience in managing urological cancer. He has been lead researcher of important clinical trials in this field that has led to approval of some new therapies in the last years. As an example, he was first author of Javelin, that assessed the role of avelumab maintenance therapy in the first-line treatment of metastatic bladder cancer. The focus of the session is discuss bladder cancer. On the first part, Dr. Pauls will give us a presentation assessing this issue. After that, we have a brief discussion, and then I will present two real cases to discuss a bit about local advance in the bladder cancer. I encourage all of you to participate of the session. You can send your questions by chat or WhatsApp. It's a hybrid event, so we have some participants here in Horizonte Institute and others connected remotely. And now, I would like to invite Dr. Pauls to give us your lecture. Thank you for accepting our invitation for this discussion.
Thank you for inviting me. I've gone through my slides very quickly. I'm Tom Pauls. I'm going to talk today about progress in the treatment of urothelial cancer. I have a number of conflicts of interest. The principle of treatment of urothelial cancer in the frontline setting has been largely based around platinum-based chemotherapy. Historically, we've given gemcitabine and cisplatin for those patients able to have cisplatin, and gemcitabine and carboplatin for those not able to have cisplatin. It's been a firmly held belief that cisplatin is much more active than carboplatin, although that's an area which has never really been proven in randomized trials. And the second area of controversy is around the PD-L1 biomarker. In the cisplatin ineligible patients, there is a label for PD-L1 positive patients to receive atezolizumab or pembrolizumab. That's based on two single-arm trials given at the bottom of this slide here. You can see the number of patients to support those labels is very small. These are non-randomized trials. Actually, it's turned out the PD-L1 biomarker is largely unreliable. There are 5 different types of the PD-L1 biomarker, each giving different results, depending on the percentage positivity, the tumor cell, or the immune cell staining. Here indeed is some results looking at biomarker-driven trials in urothelial cancer. I've been involved and led many of these trials. All of them that have been biomarker dependent have been negative. The biomarker has not been successful, and I think we need to come to a point soon where we stop using the PD-L1 biomarker. It's also true that most more recent data suggests that carboplatin is not that much worse than cisplatin. This is non-randomized data from the Danube study, which enrolled 1,000 patients. Patients, depending on the clinician, were given carboplatin or cisplatin. These patients had a performance status of 0 or 1. You can see here the progression-free survival and the response rates are almost identical. The overall survival is about 20% better for cisplatin, but the tail of the curve is the same. Overall, I think it's fair to summarize that gemcitabine and carboplatin is almost as good as cisplatin and carboplatin, if not the same. This is not a huge difference between the two drugs, and indeed, this is an attractive option for patients. The reason why that's the case is we've tried to supersede chemotherapy, gemcis or gemcarboplatin, and not been successful. We've tried 3 approaches: immune therapy in biomarker positive patients, immune chemotherapy combinations, or sequencing immune therapy after chemotherapy. The first approach, looking at single agent immune therapy, showed that single agent immune therapy was less active than chemotherapy in terms of response and progression-free survival. Chemotherapy is better at getting initial control of disease. Also, we've learned that the biomarker has not worked in this frontline setting, selecting patients who benefit from immune therapy rather than chemotherapy. Indeed, when you look at response rates across the board, you can see that the green column, chemotherapy, outperforms the red column, single agent immune therapy. And this applies for pembrolizumab, atezolizumab, or durvalumab. And this is the durvalumab data presented here. You can see the same effect with pembrolizumab versus chemotherapy. And so the uncomfortable issues, which I think I've described to you so far, is that it doesn't look like cisplatin is in a different league from carboplatin. Gem-carbo looks active. And indeed, the immune checkpoint inhibitors seem active irrespective of cisplatin eligibility. The principle of unmet need for this carboplatin-based population is actually quite complicated and may be outdated. The PD-L1 biomarker does not exist as a single entity. It's complicated. It's not been helpful in selecting patients. And therefore, immune checkpoint inhibitors are active in selected patients with urothelial cancer, but selecting them based on cisplatin eligibility or the PD-L1 biomarker is not supported by the data. The chemotherapy combination data is equally challenging. It does not look like by adding immune therapy to chemotherapy that we see increased response rates, better PFS, or overall survival. And indeed, if these curves do go apart, they only go apart after the chemotherapy has been stopped. You can see here the response rate for chemotherapy by itself is 44% and only 47% for atezolizumab plus chemotherapy. This suggests there is antagonism between chemotherapy and immune checkpoint inhibitors in urothelial cancer. It's not clear why this is different from lung cancer, but this appears to be the case. And for that reason, the third approach of sequencing chemotherapy and immune therapy together appears the most attractive. In the Javelin trial, patients were given avelumab or best supportive care. 4 to 6 cycles of chemotherapy were given. Patients who had stable or response to treatment were included in the trial. Overall survival was the primary endpoint. The overall survival hazard ratio was 0.69, representing a 31% reduction in the risk of death. The avelumab median survival was 21 months. The curves went apart and stayed apart. Forest plot analysis revealed avelumab outperforming best supportive care across broad subgroups of patients, irrespective of the presence of visceral metastasis, the type of chemotherapy, or the response to chemotherapy, or indeed the PD-L1 biomarker. Progression-free survival also favored avelumab. You can see a plateau on the curve here at 30%. The hazard ratio of 0.62 is also statistically significant. This plateau underlines the hypothesis of immune therapy that subgroups of patients go into a durable remission. One of the questions that I'm most frequently asked is, do subsequent therapies influence the outcome of these patients? And in the Javelin trial, did enough patients get subsequent therapy to be representative? In real-world data, only 25% of patients with urothelial cancer get subsequent therapy. I realize this is a somewhat selected population. Nevertheless, in trials that I performed, such as the lapatinib maintenance trial, only 30% of patients got subsequent therapy. Here, you can see 60% of patients getting subsequent therapy, 45% of which was immune therapy. Together, I think it's reasonable to say two things. Second-line immune therapy is too late for many patients for two reasons. Number one, the cancer is growing fast and we know response rates are low, but also many patients don't get to second-line therapy. Overall, I think this data set represents the real world quite nicely. We also showed that maintenance of avelumab was not associated with a significant deterioration in quality of life. 2 models were performed. This is one of those 2 models, and you can see the quality of life was maintained with avelumab, which is outlined in blue. We then move on to a biomarker component of the trial. In this study here, you can see that the TC expression and IC expression, the combined biomarker, was statistically significant at 0.56. However, when you pick apart the component of the TC, tumor cell component, and immune cell, the immune cell staining, you can see the tumor cell component had much lower hazard ratio of 0.35, whereas the IC staining was more prognostic, with both arms doing better. Together, these data suggest that the TC component is more predictive of response to immune therapy, while the IC component is more prognostic. These data are provocative, but not practice-changing. As I said before, I think we need to move on from the PD-L1 biomarker, and the first place to look is tumor mutational burden. Tumor mutational burden gives a surrogate for tumor complexity. More complex tumors require greater evasion from the immune system and higher expression of immune checkpoints. Many of these immune checkpoints include parameters beyond simply PD-L1, which may be why it's a good surrogate of response. You can see here in the dark blue, TMB high, avelumab treated patients. Dark red is TMB high, best supportive care treated patients. In this, and the other 2 curves are both TMB low. The dark blue stands out, suggesting that this model may be predictive. We move on to single genes. These are volcano plots. On the left, avelumab. On the right, best supportive care. On the left plume of the volcano are genes associated with response to therapy. These genes include components of the innate and adaptive immunity. You can see here that there are key genes associated with macrophage activity, dendritic cell activity, as well as established interferon gamma and, of course, CD8 type signatures. These don't occur with best supportive care, suggesting these genes may be predictive. And actually, when we look in more detail, what we can show when we're looking at gene signatures is innate and adaptive immunity being involved. Adaptive immunity, T cells and B cells, whereas innate immunity, natural killer cells, macrophages, and dendritic cells. Overall, at this point, it's fair to say that the combination of adaptive and innate immunity together are really important in driving responses. And simply looking at PD-L1 or tumor mutational burden do not give us all the answers that we need. Enfortumab vedotin is an antibody drug conjugate. In this randomized phase 3 study, it was tested against chemotherapy. This was in patients who had progressed, whose cancers had progressed after chemotherapy and immune therapy. And indeed, this is exactly the maintenance avelumab population. The hazard ratio of 0.70 is statistically significant. This represents a new standard of care. Therefore, from a global perspective, if we had unlimited approvals, because enfortumab vedotin is not approved everywhere at the moment, the standard of care, in my opinion, would be frontline chemotherapy, maintenance avelumab in those patients that are not progressing, and enfortumab vedotin as standard second-line therapy. These data are important because enfortumab vedotin and pembrolizumab together are being tested in combination in frontline metastatic disease. This is a study for the future, and I hope it's open in Brazil, and I hope you're able to take part. FGF inhibitors are another weapon that we have in individuals with FGF alterations in their DNA. This is only based on single-arm trials as things currently stand with erdafitinib. Response rates of 30 to 40%, progression-free survival of 5.5 months is modest. Overall, I think it's reasonable to say that this is less attractive as it stands than enfortumab vedotin, and would probably be a fourth-line type therapy for those patients with FGF alterations. In this study, we looked at patients with FGF alterations in red and pink, and we looked at single agent and combination therapy. What we showed was the addition of the second drug, the addition of uvalimab to the FGF inhibitor, did not result in a bounce in response rates. We also showed that those patients with FGF alterations had low immune signatures. It may be that unlike enfortumab vedotin, FGF inhibition is difficult to improve outcomes in this population when given in combination with immune therapy. You can see from here the waterfall plots showing that FGF alone and uvalimab alone perform about the same as the combination. I think the last slide I wanted to show you was a biomarker slide around tertiary lymphoid structures, or the second to last slide. Tertiary lymphoid structures are immune globes of active immune cells, but also inactive immune cells such as FOXP3. They're essentially immune active components within the tumor. We now know that tumors are not evenly distributed with CD4 and CD8 and other key parameters. They tend to be formed into these tertiary lymphoid structures. In the future, I think we'll be looking at tertiary lymphoid structures in terms of response, and we're beginning to see exciting data in that respect. Finally, we're also measuring circulating tumor DNA. In this trial, after surgery, we measured circulating tumor DNA in atezolizumab-treated patients or observation. What we showed was circulating tumor DNA was powerfully prognostic, but also, if you follow the dark blue curve and the dark red curve, it's also predictive of response to atezolizumab. It's possible we'll be using tumor-based biomarkers and immune-based biomarkers in the future, because this slide here shows circulating tumor DNA with tumor-based PD-L1 and TMB. And we can see for those patients that have immune-active tumors, PD-L1, TMB, they do even better if they're ctDNA positive, where the ctDNA positive tumors that overexpress inhibitory signals such as TGF-beta and angiogenesis do less well. This is a prospective study investigating circulating tumor DNA further. There's a chance that circulating tumor DNA will replace radiology in urothelial cancer in the future. In that, post-cystectomy, or indeed post-response to chemotherapy, we'll be looking for changes in circulating tumor DNA rather than measuring CT scans. What can I say in summary? Well, I think where I started was that the PD-L1 biomarker has not particularly helped us in urothelial cancer. I think that applies for other biomarkers as well. I think circulating tumor DNA at this stage may be more promising. In the end, immune checkpoint inhibitors will need to be given in combinations in selected individuals and earlier in the disease. As it currently stands, single agent immune therapy in the second line setting is too late for most and not active enough. In the frontline setting, single agent immune therapy is less active than chemotherapy initially, and therefore, at the moment, the optimal approach for unselected patients is frontline chemotherapy with 4 to 6 cycles of gemcitabine and cisplatin, or gemcitabine and carboplatin, followed by avelumab maintenance therapy as the standard of care. Thank you very much for your attention, and I'm very happy to answer any questions.
Thank you, Dr. Pauls, for the outstanding presentation. So you're talking about the role of biomarkers in bladder cancer. It's very interesting. So my question is, at now, do you order any biomarker before treating patients in the first line? And what about the subsequent lines? Do you think it's important to check for FGFR with patients? What is your impression about this? What do you do in the clinical practice about?
So I think as things currently stand in clinical practice, biomarkers have not yet been successful. I think the only biomarker that would change my decision-making would be FGF alterations. Am I interested in high tumor mutational burden? Yes, in broad terms, but it wouldn't change what I would do. I wouldn't select therapy based on TMB. Does the PD-L1 biomarker change what I would do? Well, there are 5 different PD-L1 biomarkers, as I've shown you. Some are predictive, some are prognostic. We just don't know enough about it. The PD-L1 biomarker would not currently change what I would do. And therefore, the only biomarker where we can reliably say we may change what we do is indeed FGF. But as I said before, the FGF alterations, I think particularly FGF3, do appear targetable with erdafitinib, but erdafitinib is not yet proven in randomized trials to be beneficial. And therefore, as things currently stand, even that biomarker selected population, I would put in perhaps the 3rd line setting after chemotherapy, maintenance of avelumab, enfortumab vedotin, and then erdafitinib. So the answer to the question is we haven't made great progress in biomarker discovery in urothelial cancer yet.
Great. My other questions would be about the 2nd line. So you have discussed it clearly. You prefer enfortumab vedotin for unselected patients. I think I agree with you because we have now a phase 3 trial that is comparative. So do you consider giving IO only for any kind of patient or any disease scenario on the 1st line treatment? I mean, some very elderly, frail patient that is not able to tolerate even carboplatin. Do you consider giving it for any patient? And in this scenario, you order some biomarkers. Do you need the PD-L1 to offer this kind of treatment?
You've asked a really difficult question there, and the answer to your question is yes. So there are certainly, for those patients, and it's probably about 10% of the population, for those patients that simply can't have chemotherapy, single agent atezolizumab or pembrolizumab are attractive alternatives. What I can tell you is the drugs tend not to work well in patients with visceral metastasis, so bone metastasis and liver metastasis particularly. The PD-L1 biomarker, as I said before, is controversial. The hazard ratio in the PD-L1 positive pembrolizumab treated patients is lower, it's worse, than the hazard ratio in the biomarker negatives treated with pembrolizumab in Keynote 361. It's powerfully prognostic, but it's prognostic for both chemotherapy and immune therapy, which is why I would not be using the 22C3 biomarker. The 142 biomarker that's only positive in 25% of patients has better results with atezolizumab as things stand. There are many people who feel pembrolizumab is a more active drug than atezolizumab, but actually atezolizumab does currently have the more compelling data in the frontline setting. In patients with lymph node only disease and low risk disease, immune therapy instead of chemotherapy followed by immune checkpoint inhibitors may be an alternative. The issue is, for the vast majority of patients, it's easier and safer to get initial control with chemotherapy, and then once you're in control, sequence maintenance of avelumab. The problem with giving frontline immune therapy is most of the patients who get frontline immune therapy progress straight through treatment, irrespective of the biomarker, and those patients that progress through the treatment, many of them will go on and die quickly of their cancer. So this is a very challenging area as it stands, and in reality, it's probably easier to approach a one-size-fits-all model of single agent or combination chemotherapy, maintenance of avelumab, as the standard of care.
Right. And you show the graphs of overall survival that show us that patients that receive chemotherapy also, some of them also have a long-term survival with platinum-based chemotherapy. Do you think what will over-treating patients? I mean, in a scenario that we have less resources, so it would be feasible to give a sequential chemotherapy upon progression, or do you think it's a much less effective strategy?
So even the patients that have had a complete response, and I didn't show these curves, but even the patients that have a complete response to chemotherapy, the median time to progression is 4 months. So bladder cancer is different from kidney cancer and prostate cancer. In kidney cancer, we know if you have a complete response with immune therapy, many patients go on for years without progressing. In bladder cancer, that's not the case. It's only 4 months. So that's the first issue. The second issue is that we all know patients with bladder cancer, when they do progress, their disease is aggressive. Now, yes, of course, it will be possible to salvage some patients with pembrolizumab second line. But for every patient you salvage second line, there'll be another patient that progresses and never gets second line therapy. So when you have a patient in front of you and you say, we've got a choice now, we can wait till the cancer comes back. Well, let me go again. You say to the patients, immune therapy in about 20% is associated with long-term durable remission. You now have a choice. You can get that immune therapy now, or we can wait until the cancer comes back. The problem is if we wait till the cancer comes back, there's a 50% chance you won't be well enough for the chemotherapy at that time. And I think when you talk to patients in those terms, they say, I would like to have the chance of that durable response now, rather than waiting till later, where when the cancer comes back, it's going to be harder to treat.
Okay. I have two cases, two real cases here.
Let's look at those now. That would be terrific.
Could we discuss?
Yes, we can.
Two cases of localized and locally advanced disease, because we have urologists in the audience. So I think it's important to discuss, have your experience in this scenario to discuss localized and locally advanced disease. So let me show my presentation. These are my disclosures. So the first case is a 58-year-old, a healthy male, well-controlled hypertension and heavy smoker. He had a gross hematuria for 1 year, and urinary ultrasound showed bladder lesion suggesting malignancy on the left lateral wall. He got first 2 RBT on October 2020. There was a large friable and bleeding papillary lesion, and the pathological report showed a urothelial carcinoma, PT1, low grade, no muscle layer representation. Because of that, he did a second 2 RBT on November 2020, and that showed multifocal confluent sessile lesions on the left lateral wall, spreading to dome and inferior walls. Other papillary lesions on the anterior wall, so a very advanced disease at cystoscopy. The pathological report showed a urothelial carcinoma, now a high-grade disease, and muscular invasion, PT2. So we did CT scans. So one question is, how do you stage patients with locally advancing urothelial carcinoma? Do you do CT scans, MRI? What do you think about the
so my take on this issue is we tend not to use FDG PET scans. We use CT scan of the chest, abdomen, pelvis for the majority of patients. We tend not to use MRI, although I accept you get better pictures of the bladder that way. The issue is for those patients with histological T2 disease, the only question comes when it's T4A or T4B about whether or not it changes decision-making. And of course, CT scans are actually very good at looking at lymph nodes. So for straightforward muscle invasive urothelial cancer, my preference is to do a CT scan and get on with treatment quickly. One of the things we never talk about or don't talk enough about is the more tests we do, particularly the more unnecessary tests we do, the longer it takes and the more contradictory data we get. And so my preference, as things currently stand, is to dive in relatively quickly, do a CT chest, abdomen, pelvis, and start neoadjuvant chemotherapy quickly.
Okay, and in your cancer center at Bart's Cancer Center, do your urologists use enhanced cystoscopy, I mean blue light and narrowband imaging to evaluate and to survey patients with non-muscle invasive breast cancer? This is a routine in your center.
Yes.
What do you think about enhanced cystoscopy?
So it's not used as much as it should be from a global perspective, but it does increase the sensitivity and specificity, and it's something which we do use a lot of in the UK, and not just our centre, but it is a standard treatment, and I think it's a helpful standard treatment.
Right. Let's go ahead. So this patient did a CT scan, chest normal, abdominal and pelvis showed multicystic kidneys, large contrast enhanced and physical lesion, 45 millimeters, muscular invasion, no lymphadenopathy. Small lesions on the pubic and ischium with lytic aspect. So it's a question about secondary spots, but the radiologist was not sure about that. We did a bone scan, and there was a low probability of metastasis. When you have a conventional scan that show that that's not very sure about the presence of metastasis, do you think it's appropriate to do a PET scan, or you?
I don't know the answer to that question. So that's a difficult question, isn't it? I mean, you know, when you've got a bone scan that shows an abnormal area, and it would be a patient that would otherwise be going to have curative surgery, we would be doing an MRI scan probably.
Okay.
So we would MR the area of an abnormal. If we got an equivocal bone scan report, that would make me nervous.
So at this time, the patient was referred to medical oncologist. The first appointment was December 2020. His creatinine was 1.61. So the creatinine clearance is 55 millimeters. So it's almost ineligible, but still eligible for cisplatin. The performance status was 1 and no bone symptoms. So he started cisplatin with gemcitabine with dose adjustment for cisplatin. And I referred this patient to orthopedist that decided not to biopsy. He saw the images and was very, very confident that is not a bone metastasis. So we continue with chemotherapy. He completed 3 cycles of cisplatin gemcitabine with good tolerance, no G3 or 4 toxicities. And on May 2021, he did an open radical cystectomy with incontinent heterotopic derivation, Bricken, plus retroperitoneal lymphadenectomy. So the pathological report, a complete response. So it's a very interesting case. And my question is, do you think not do cystectomy for patients that have clinical complete response? Do you think it's possible for those patients who will decline, eventually decline because he had a complete response?
At the moment, at the moment, you've done the right thing. But of course, patients who are responding don't want to have a cystectomy. The danger is you don't know until you've done the cystectomy whether they've had a complete response. I know you can do a TURBT or a cystoscopy. As it currently stands, cystectomy remains the standard of care, even in these patients. There are ongoing randomized trials with immune checkpoint inhibitors in this space and bladder-sparing approaches. Those bladder-sparing approaches include radiation therapy, but also we're looking towards doing observation or ongoing immune therapy for patients with a complete response.
Yes, we wait for this data, but it's an interesting situation. I mean, and what do you think about the data from adjuvant immunotherapy? We had a recent trial that assessed the role of nivolumab as adjuvant therapy for high-risk patients. It's not this kind of patient that I showed, but what do you think? Are you enthusiastic of adjuvant immunotherapy for high-risk patients? What do you think?
So my current position is that without any overall survival data for the nivolumab trial, and with a negative trial for survival with atezolizumab, we currently can't confidently state adjuvant therapy is a benefit to these patients. We know the adjuvant therapy is associated with significant adverse event profiles. And therefore, in summary, it's fair to say that the nivolumab adjuvant data looks promising, but until we see more data, particularly for survival, we should be very cautious because we currently have a negative trial with a different immune checkpoint inhibitor that looks equally active in urothelial cancer, which has not shown a survival signal.
Right. Let's go to the second case and the last one. So this is a 57-year-old male, a current smoker, 30-pack years, well-controlled hypertension. In November 2010, so 11 years ago, he had a gross hematuria and ultrasound showing a left renal mass. So he did partial nephrectomy that showed a papillary renal cell carcinoma, 4 centimeters diameter, stage PT1A, PN0. So during the follow-up in 2012, this guy had an abdominal ultrasound that identified a papillary lesion on the right superior wall, bladder wall. So this is pathological report, a non-muscle invasive bladder cancer, PT1 high grade, only one lesion, 2.5 centimeters, and no CIS. So he received a 6-week induction course of BCG, 80 milligrams, followed by maintenance therapy for 2 years until 2014. So the follow-up with image were normal, cystoscopy in 2016 normal, and no clinical symptoms. So he did a Rhine cytology on January 2020 that was suspected for neoplasia. So my question is, do you survey these patients with Rhine cytology, or do you think it's important?
I think this is difficult, isn't it? Because you're 6 years later. And it just shows that these tumors can come back. It's probably a new unrelated tumor. These patients, sensible approach would be to continue these patients on some form of surveillance. We know that they're at increased risk. But the question is when you stop. And, obviously 3 monthly cystoscopies, 6 years down the line or 7 years down the line is beyond the call of duty. So the answer is we keep an eye on these patients, but we tend to reduce the frequency of their follow-up. But here you've done the right thing, obviously.
He did a urinary ultrasound in January 2020 in normal bladder, no alterations. And the cystoscopy in March 2020 showed multiple red patches along the bladder walls. And the urologist did random biopsies that show a CIS, so a carcinoma in situ. This patient presented with this disease. So we did a pelvic MRI at this time that show a right superior bladder wall thickening, 5 millimeters depth, 42 millimeters extension, suggestive of inflammatory alterations, post-surgical manipulation. So this is the images of this alteration. And due to BCG shortage, I think it's a problem in England as well.
Yeah,
it's a problem worldwide. So we start with gemcitabine intravesical, 100 this dose weekly for 6 weeks. So 3 months later, the BCG was came. So we did 5 weeks of induction BCG. That was stopped by intolerance. So we can't do 6 weeks at that time. So he did a cystoscopy in January 2021, and he had a partial improvement of the red patch lesions, partial improvement, but the pathological report still showed moderate atypia of undetermined significance, suggesting immunohistochemistry to evaluate the presence of little spot of CIS. And the immunohistochemistry showed CIS. So my question is here, if you consider this patient BCG responsive, or what your impression, what do you consider a BCG responsive patient, and what would you option for this patient?
I mean, you've gone for 3 months later and you've given some BCG induction. You haven't given, he stopped by intolerance. So he hasn't had the full go at BCG, but it's not been successful. It doesn't sound like you can give him more BCG. So you've come probably to the end of the road. And one of the questions now would be, well, where do we go from this? And CIS after 6 weeks of induction BCG and 5 weeks of gemcitabine, I think that you can't remain on BCG because he's not tolerant of it. So I think that's out. I would probably not give more IV chemotherapy. I think that, trying with pembrolizumab is reasonable under the circumstances. I think chemo-rad for CIS is not indicated. And I think radical cystectomy is clearly on the table.
Okay. Pessoal. Sorry, Dr. Pose, my connection is down. There was a breakdown here.
Feel free to describe what you did next.
Can you hear me, Dr. Pose?
Yes, can hear you well.
Because my connection of my computer has breakdown here. But I think that's it. We don't have any question here. So I would like to kindly thank you for your time here with us. So it was a great pleasure for us this evening. So thank you very much.
It was a real pleasure, Elias, to chat to you and to be with you in your beautiful new hospital. I hope you manage to, or we manage to get together soon. and we can meet and do this in person.
Thank you very much. You are invited to come here with us.
That's very kind of you.
See you soon at anywhere in any meeting.
Thank you, Elias, and see you soon.
Thank you.
Bye-bye.
Good evening.